Kia ora, everyone. My name is Romy. I'm your chair for this session of the Pecha Kucha Kei Te Mura o Ta'ahi. And in this session, we will have 4 speakers, and how it will work is following introductions. The speakers will each do their presentations. Then we will move into breakout rooms for 15 minutes of Q&A with your chosen speaker. Before we get started, just a reminder of our community guidelines. Remember that our speakers are students or recent graduates, and we're all on learning journeys. And so aim to be respectful. So we are curious, open, and respectful. We make generous assumptions. Remember confidentiality about personal stories that people share. One person, one mic, so refrain from interrupting. We speak from our own experience. Remember that no one knows everything, but together we know a lot. Make space for others and take space for yourself as well. We can't be articulate all the time, and we don't take ourselves too seriously. Also, just remember that the chat is enabled, so please feel free to use it. And there are moderators and tech support on hand if needed. So please raise a hand or comment in the chat. So I'm going to introduce all of our speakers for this session and then hand over to them to begin the first presentation. So in this session, we've got Monli Ikua up first. So Monli will be presenting about Whitia Kia ora, Bridging the Gaps. Following Monli, we will have Kim Arrowsmith, whose presentation is titled Haumaru Panuka Oranga, a qualitative study about Kaumatua Māori and their experience of mobility and transport in Aotearoa. After Kim, we will have Maithili Mea, whose presentation is titled 5 Features of a Good Tool for Whānau Engagement. And our final speaker will be Becky Sheehy, whose presentation is titled Māori Experiences of Physical Rehabilitation in Aotearoa. So those are our speakers for this session. And so to start us off, we have Monli. So over to you, Monli.
Kia ora, thank you. Cool. Tēnā koutou katoa he uri tēnei no niue, ko Monli Muliamasili Iaho. I'm the research assistant on the Whitia Kia ora project. And I'll be presenting this project on behalf of our team. As you can see, I also have the privilege of working alongside some exceptional wahine. So this diagram represents our rationale. In Aotearoa, Māori and Pacific children are disproportionately affected by rheumatic fever. And research also shows that there's a gap in patient voice and agency. So what our project aimed to do was to develop a model with rangatahi and their whānau. This model of care that we could use. There's also a skip component that I won't be covering today. So what we did is we conducted interviews and workshops in person and online with 16 Māori or Pacific participants who received Bisolin. We utilized both kaupapa Māori and Pacific approaches, and this is also a rangatahi and whānau-led and centered approach to solutions. So there are 3 phases to our project. Phase 1 is to develop the model with insight from rangatahi, so teenagers, young adults, and then whānau and health professionals. Currently, we're looking at implementing the model in Huntly, so doing that over the next 12 months. And then in phase 3, we'll evaluate the model. The 3 key themes that came out of our interviews the first was misalignment with colonial health systems. So whānau talked about the language being clinical and Western, being on the periphery, not the center of care, limited whanaungatanga and trust, limited support outside of the health sector. The second theme that came out of our interviews, whānau talked about life being defined through disease status. So things that came up, RF, rheumatic fever eroding the identity, confidence, and aspirations, being blamed for having rheumatic fever, which of course shifts the blame on policy and practice, and there being some fear and mistrust. The third theme, whakakaha, to strengthen. Whānau talked about following the following helping them to cope. So ongoing communication, flexible care management, culturally safe spaces and engagement, whanaungatanga, and then incentives and distractions. The information that we gathered from all of our interviews produced the following model of care, and I'll go through each of these individually. So the first part of the model is to develop a healthcare plan. So in other areas of health, you might receive a management plan, for example, with diabetes, and we developed this with insight from Te Whatu Ora and Mana Kids. We then tailored it to the Waikato region, which is where our model will be based. The second was to employ a whānau navigator to help rangatahi and their whānau just to access the care and support that they need. Next is to provide incentives and distractions. The needle that these tamariki rangatahi get is very big, and so this is just kind of to help them to go through that really difficult procedure. The next is cultural safety training to healthcare professionals in Huntly, just to support culturally responsive models of engagement between healthcare professionals and whānau. So we took scenarios that rangatahi raised in our interview to create videos that would guide us through these discussions. The next is to provide written, visual, and verbal resources on RF. So we combined all the resources that we could find on rheumatic fever, and then we ranked them based on whether the info was culturally appropriate, if it was simple, and if it was whānau-centered. The next part of our model is to host peer support meetings with champions. So we would provide online or in-person spaces for rangatahi with rheumatic fever and their whānau to share experiences. The next is to provide transport support. And this would be implemented by the whānau navigator. So this is the impact of the research. One of the mama said, thank you very much from the bottom of my heart for doing this. It's quite amazing. Like, I'm really grateful to be involved in this. Which brings me to the end. For those of you that are interested in keeping in touch or would like to know more about the model, I've just added my email address at the bottom there. And then just before I finish, I want to thank those who have contributed to the project, especially the participants who trust us with their knowledge and experience, Te Whatu Ora Waikato, Kio Kids, Tō Maora, NHC, and the research group. Kia ora.
Kia ora, Monley. Thank you for that presentation. I really got a sense of the amount of work that's gone into that and such important research and amazing action coming out of that. So thank you for sharing your research with us. Next we have Kim Arrowsmith. So I'll hand over to you, Kim.
Kia ora. Ray, are you able to put the slides up? Kia ora koutou, ko Kim toke ingoa no Tamaki Makaurau aho. I am a research fellow at National Hauora Coalition, and this presentation is about Haumaru Panuku Oranga, a research collaboration between National Hauora Coalition and the University of Otago. I will start this presentation by telling a story about Wayne, an interviewed participant, not his real name. Wayne was a kaumātua working as a leader in a mental health support service, and he was creating a service specifically for kaumātua. This was his own initiative. He was asked to come out of retirement due to a lack of healthcare workers who had leadership experience. I think of him in relation to this project because he was in a position of power and had an informed perspective of how isolated kaumātua were. Wayne is very typical of the kaumātua in his region. He was still working. He was starting to become concerned about how he would transport himself as he got older. He still wanted to serve his community, but realised that this wouldn't be forever. Through Wayne and his story, I could see the importance of connection and relationships and how transport is so key to connection and maintaining a sense of belonging. This study set out to find what supported Kaumatua and their transport needs in Aotearoa, New Zealand, and what were their preferred modes of transport. When commissioned, NHC named this project Haumaru Panuku Oranga, meaning wellness in the next life. Our research team at NHC consists of Rachel Brown, CEO of NHC and researcher. There should be Dr. Ainsley Suakribit there as well, who is the Director of Research. Me, Assistant Research Fellow and Registered Nurse. Tera Phillipson Puna, Research Assistant. Shannon Lailula, Research Assistant and Tikanga Advisor. And Monli Muliao Basayali, Research Assistant. Our research questions were, how do Kaumatua manage their transport needs in Aotearoa? What are the different modes of transport Kaumatua use? And what are the factors that impact Kaumatua and their ability to travel at this stage of life? NHC was asked to be involved because of its Māori-led research team and expertise with kaupapa Māori methodology. Alongside the study was a purpose-built Māori advisory team who collaborated with the research during the study design, data collection and analysis. For data collection, the team travelled the motu from Northland to Dunedin and saw 50 Kaumatua and whānau participants between July and November 2023. We combined individual interviews, wānanga, go-alongs, and made sure that these were led or overseen by Māori researchers. Here are some photos of us in the field at Tairāwhiti. There is Shannon leading a wānanga at Tupuia at the hospital there. We had amazing support from the communities we engaged with, and this was critical to our success in data collection. Then in the new year, we as a team collated the data and analysed using thematic analysis. We specifically took a strengths-based approach to the analysis of the findings and consulted with our advisory group along the way. These were the most common modes of transport reported. As you can see, waka or a car was the most commonly reported mode. However, hikoi, horses and hitchhiking were frequently reported as well, especially rurally. When coding the data, we managed to put together a Venn diagram of the codes that overlapped between rural and urban. As you can see, poor internet use and access, heavy reliance on whānau, feelings of isolation, feelings of disrespect from Pākehā, high cost of living and high activity were reported by Kaumatua and their whānau in relation to their transport needs. We managed to convert our codes into a coding framework that shows where our themes, sub-themes and codes fall. Our framework answers our central question, how do Kaumatua manage their transport needs in Aotearoa? And the answer is with inbuilt resilience. Resilience created by rohi or region, whānau, social skills and needs. The social aspect of transport came through as a significant finding where Kaumatua reported that they sought out transport that meant they could be social at the same time. This contributed to leaning on whānau for rides and transport in general. One of the most interesting experiences we had as researchers was our participants' feedback about research itself. They were sick and tired of researchers coming in, talking about issues and then leaving without any steps taken to fix the reported problems. We were told by participants in Tairāwhiti that they would like to see an outcome from this research. We have been thinking about how we can engage politically, speaking truth to power in our roles as researchers. There is definite scope for transport and social policy change based off the findings gathered. However, this will involve a lot of mahi, consultation and strategic planning to mobilise the issues related to policy. I would be interested in hearing your feedback about this. Our next steps will be to try and publish a manuscript and to return to the sites where we collected data and report back. Then we will start working on ways to implement our findings to make meaningful change to the communities who provided us with their data, Atonga. Ngā mihi nui.
Kia ora, Kim. Thanks for your presentation. It was great to hear research using a kaupapa Māori research frame and exploring the strengths in a community. And then also I liked how you brought the politics in towards it towards the end. So thanks so much for sharing. I'll pass over now to Maithili.
Kia ora tātou. Ray, could you bring up my slides, please?
Give me 1 second. I have to make one adjustment.
Yeah, sure.
Oh, I'm sorry. 1 second. I have to get to where I can share my screen. Give me 1 second. I apologize.
Okay.
Here we go. Josh.
Thank you, Ray. Tēnā tātou. Ko Wai'o he uri tēnei no Maharashtra, India, no Maithili, ko Maithili me he aho, he tanga tiriti aho. So my name's Maithili, I whakapapa to Maharashtra in India. I'm tangata tiriti here, and I am a research fellow at the National Hauora Coalition alongside Kim and Mon Lee. So today I'm presenting to you from a study carried out in-house at NHC last year. And the study set out to identify and test tools to improve how we do whānau engagement. So it's a study funded by an HRC Community Advancement Grant. And this diagram shows me receiving the brief and going, what is a tool? And what is a good tool? And who decides? So I like this whakatauki for framing the study because it reminds us that good leadership hinges on great listening and honouring what people have told you and treating their whakaaro as taonga. And it was really important to us that the engagement tool could do this. There's loads of good reasons to be sort of whānau informed in primary health and social services. These are just some of the factors raised by this article, like community informed service has been linked to improved immunisation rates, reduced cardiovascular risks, positive mental health impacts, and improvements to service. And of course, if we think about Te Tiriti, specifically Article 2, Māori have a special right to be partners in developing healthcare and to exercise tino rangatiratanga regarding their health and well-being. At the very, very, very best, we'd hope that finding a good tool for good whānau engagement and broad uptake of effective tools like this that do work for Māori can be part of centering mana motuhake, sovereignty in Hauora, and drive broad systemic change where whānau shape health systems and health services, not the other way around. So this was a qualitative study informed primarily by principles of ethnography and kaupapa Māori methods. So in the first place, this is a diagram roughly of NHC and its governance, and on the borders are where the sort of frontline workers and researchers are sort of interfacing really regularly with whānau. Recognizing, of course, that we're all whānau. So the research process was pretty much whakawhiti kōrero with all of these people at various stages, frontline workers initially one-on-ones, and then I go back and synthesize what are the gaps. I did observations and then went back and went, what are the gaps and what are tools that could address them? And the first tool we decided through that process that flipped by too fast was that relationships are everything. Meaningful relationships support how effective a tool is, and trust and process as well. So that's super key. The second quality of an ideal tool is that it needed to protect kaimahi's time and let them focus on their day-to-day mahi. So one of the things I did early on was observations with kaimahi, going on ride-alongs with people who did social work. And the level of embodied commitment that Kaimahi practice, especially who works one-on-one with whānau, is immense. Across our social work team, they don't eat and drink all day to avoid toilet stops because those are inconvenient. There's a lot of paperwork. They're juggling a schedule, being really responsive to whānau, appointment times changing on the fly, having mental maps of who else they could visit in an area, for example. So can't burden them more. The other thing that came up a lot is that we need better processes for actually listening and channeling whānau insights, which are those scattered drops around the sides, for them to be filtering up through the system, not just staying at provider level. Another criteria, can we actually act on what we're asking for? So this was a question discussed by Kamahi across several hui, questioning whether it would be unethical to ask after things, to ask open-ended questions and hear back responses about things that NHC can't action. Like, for example, if we hear a lot about whānau experiencing domestic violence when we don't actually run any services to support people with that. And what it came out with when we're sort of juggling the ethics of this is if we can't meet those needs, then we must commit to learning from whānau to better resource ourselves to meet needs in the long term. And if that is the case, if we're not able to immediately respond to the criteria that people raise and the needs that people raise, then that's crystal clear to the whānau that we're inviting information from. Do they know how much impact to expect from their taonga and timeframes for an institution to process feedback? Are we communicating these with clarity and humility? And reciprocity is not like for like. It's the organization gathering information for its health agenda and also meeting people where their aspirations are at. So it's delicate stuff. So we put together this criteria for a good tool. And this actually acted as a really helpful shorthand check against which we ended up generating a whānau engagement ecology, which was not just one tool, which I should have known, but actually a whole system of tools was the place that we landed. And this is a system that has to pull together various tools, maps, processes of relationships and roles for holding, reflecting on and acting on whānau feedback. So it's separated into 3 systems where there's tools for gathering whānau feedback, processing, reflecting and action. Mātauranga Māori informed principles and quality processes are in there, as well as data sovereignty principles. And ideally to be able to have this overseen with whānau at an advisory level, so like whānau advisory boards. And that's my time. Our next steps are to actually implement this at clinical practices NHC owns and actually evaluate it, tinker with it with whānau and Kaimahi input and support. So thank you for hearing me out on that.
Kia ora, Maithili. Wow, that's awesome research into such a big and complex question. And there were quite a few comments in the chat about your data visualization of visualizing that really big and complex question. So thank you. I'll hand over now to Becky for our final presentation.
Tēnā koutou katoa. It's great to be back again for this year's Pachá Marathon. Today I will be discussing the results of a scoping review on the topic of Māori experiences of physical rehabilitation services in Aotearoa. I would like to take this opportunity to acknowledge my supervisors, Associate Professor Dr. Diane Wipa and Dr. Julie Collis. Ko Kalani te maunga, ko lifi te awa, ko Ngāti Airangi toku iwi, ko Becky Shihi toku wingwa. I'm an occupational therapist and hand therapist originally from Ireland. Working in the health system in Aotearoa, I can't help but notice the differences and more often than not, negative experiences of whānau Māori when they engage with health services. In response to recognition that being tangata tiriti is a call to decolonisation action in my field of practice, the focus of my master's study has been to explore the experiences of Māori. This study is underpinned by a Te Tiriti o Waitangi approach and incorporates a solution focus. The study is made up of 2 phases. The first, a scoping review that I will discuss today, focusing on the broader topic of Māori experiences of physical rehabilitation, and the second is a qualitative study more specifically exploring Māori experiences of rehabilitation in a hand therapy context. Similar to other Indigenous populations who have been colonised, Māori are known to suffer a heavier burden of musculoskeletal injuries with no associated increase in uptake or access to rehabilitation services that are designed to assist in achieving and maintaining optimal function and quality of life. Rehabilitation has been recognised as an area with potential to address Māori health needs, as it shares concepts with Hauora Māori models, such as holistic approaches and recognition of the importance of cultural and environmental contexts. However, little is known about the experiences of Māori as consumers of rehabilitation services. Therefore, this scoping review aimed to synthesise what is known with a view to informing equitable and culturally safe service provision. Studies eligible for inclusion were those from the past 10 years, with a qualitative component. A total of 14 studies were included. This review incorporates the experiences of 199 Māori, both individuals and their whānau. Contexts included hospital, outpatient, and community rehabilitation. Participant diagnoses included neurological and pulmonary conditions and musculoskeletal injuries. The focus of studies ranged from therapeutic relationships and caregiver experiences to access issues and systemic barriers. 4 themes were generated from qualitative data using reflexive thematic analysis. The first 2 themes focus on the experiences of Māori, and the second 2 encompass solutions for culturally safe services. The first theme is Māori expectations for culturally unsafe healthcare become a reality during rehabilitation. Participants were found to be distrustful of health services due to past negative experiences, expecting to feel isolated and disconnected. These expectations of alienation were confirmed when participants encountered rehab services that were constrained by individualistic and medicalised approaches. The second theme is whānau are crucial for navigating cultural collisions during the rehabilitation journey. At a time of high stress and vulnerability, whānau took on roles as advocates, informal caregivers, upholders of tikanga, and navigators of rehab services and a health system that clashed with Māori notions of health and well-being. The third theme, rehabilitation is made culturally safe by embracing Te Ao Māori me ona tikanga, relates to wholeheartedly incorporating Māori ways of doing things during rehabilitation. The importance of tikanga as a source of recovery was consistently emphasised by participants. In support of this, increasing access to Hauora Māori services and boosting the Māori health workforce were suggested. The fourth theme, rehabilitation is made culturally safe through mana enhancing services, relates to provision of services that are collaborative, empowering, and whānau centred. Themes 3 and 4 are inextricably linked. The findings from this review challenge rehabilitation professionals to disrupt expectations that Māori have of receiving culturally unsafe care. The solutions proposed in this review advocate for culturally safe rehabilitation that normalises Te Ao Māori me ona tikanga and Māori approaches to health and well-being. Cultural safety has been recognised as a pathway for transformative change in the health system towards decolonisation and the eradication of health inequities. Culturally safe clinicians are those who are aware of historical and contemporary impacts of colonisation, including breaches of Te Tiriti that link to the poor outcomes and health encounters that Māori experience. In terms of mana enhancing services, culturally safe clinicians recognise Māori diversity. Clinicians need to avoid typifying Māori as a singular group rather than a culturally diverse people. Therefore, flexibility of approach should be offered as part of rehabilitation, enabling choice and empowering Māori to be Māori as guided by them. Whānau were found to make a critical difference for Māori during rehab, leading to a raft of positive outcomes, including increased participation and engagement. Autonomy and independence are taken for granted as a universally sought-after goal in rehabilitation contexts. An essential step towards countering individualistic rehab models is to adopt a whānau-centred approach. Whakawhanaungatanga was the most frequently recommended solution for the incorporation of Te Ao Māori. Whakawhanaungatanga extends beyond the well-known concept of therapeutic rapport to the formation of deeper and more meaningful connections that had the power to negate past negative health encounters. This review draws attention to the pressing need to develop the Māori rehab workforce. Māori clinicians were recognised by participants as bringing a sense of comfort and cultural familiarity, leading to a natural ease when forming connections. Increasing the Māori workforce does not, however, absolve non-Māori clinicians from engaging with Te Ao Māori me ona tikanga. It is apparent from this review that rehab services, as in other areas of the health system, are not consistently delivering culturally safe care for Māori. Rehabilitation services must create a safe space for Māori and provide whānau-centred care. In this way, Māori and their whānau can focus their energy on healing and recovery without having to navigate cultural collisions throughout the rehab journey. Nō reira, tēnā koutou, tēnā tātou katoa.
Kia ora, Becky. Such important research there into creating culturally safe spaces for Māori. And I was particularly struck by your call for culturally safe clinicians having knowledge of colonisation and te tiriti breaches. So I really appreciate you sharing your research there. So we will move into breakout rooms now. And just a reminder of the community codes is particularly important now in the breakout rooms when we are one-on-one with each other. So please have another read through that and remember to be generous with your assumptions. And if there's a lot of you in a group as well, remember to keep your reflections short, to make space for other people to share their reflections or questions as well. So yeah, please join a breakout room, and we'll see you back here in 15 minutes. Thank you everyone for joining this session. I'd like to thank all the speakers for their time and energy in sharing their research. And thanks to our partners as well, who have helped support this, this whole webinar series and as well the Pecha Kucha. And thanks to our volunteers and our webinar and tech support team.